As you learned from reading Dr. Kenneth Brummel-Smith's article, optimal aging is the capacity to function across many domains: physical, functional, cognitive, emotional, social, and spiritual, to one's satisfaction and in spite of one's medical conditions. This implies that optimal aging should be seen from a biopsychosocial viewpoint, and that the adaptation that older adults make to the many challenges of aging involves selection, optimization, and compensation. This video is designed to help you explore considerations for optimal aging from the psychosocial perspective. Growing older is a transition. Older adults progress through their own personal combination of psychological and social changes in their final life periods, and no one theory can explain all the variances of human nature or guide the healthcare professional through a specifically directed path of examination, intervention, and referral. Some of the developmental tasks, learning problems, or challenges to be solved by those in later maturity include facing the psychological trauma of being newly widowed or divorced, losing employment or living on a reduced or fixed income, losing physical vigor, adapting to changes in living arrangements, adjusting to an environment in which change and loss occur at an overwhelming rate, selecting appropriate social support choices for an effective balance between independence and dependent care choices, accepting the imminent reality of death, and developing new social rules that bring recognition and respect. I once posed a question to a group of physical therapy students, asking them if social changes were more common in a person's 20s or in their 70s and 80s. Their response was both interesting and insightful. While acknowledging that both groups were subject to frequent changes as their life evolved, they recognized that, with most social changes, older adults experience isolation. Their world gets smaller and smaller, while they experience lots of losses that tend to be negative. The students also postulated that older adults have less physical energy to cope with these changes, but more life experience from which to draw. And they recognized the tendency of the younger therapists to project their physical ability and methods of coping onto their older patients. So how does the elderly person cope with the inevitable psychological and social changes that come with getting older? Peck suggested 3 distinct areas of conflict that potentially occur in later adulthood as each person adjusts to their changing circumstances in life. First is ego differentiation versus work role preoccupation. Our jobs frequently provide meaning and focus to our lives. When retirement does occur, a significant adjustment is required as a person searches out new and appealing roles while seeking satisfaction with aspects of his or her selfhood that have previously been ignored. Body transcendence versus body preoccupation. Bodily changes in older adults may bring about a drop in life satisfaction and a growing preoccupation with bodily conditions, especially for those whom physical health was a cornerstone of comfort and well-being. Ego transcendence versus ego preoccupation. Is a person preoccupied with their loss of vigor and impending death? Or does the older adult cope by engaging in selfless, fulfilling activities that enhance the quality of life and well-being of others? This discussion of Peck illustrates the fact that older adults may employ both productive and unproductive strategies to cope with psychosocial changes. So how can we, as therapists, promote their optimal aging? It starts by active listening and gathering of facts, which can inform our perspective of each patient and assist us in selecting appropriate interventions and support strategies. Rehabilitation professionals should strive to free older adults from an age-inappropriate view of their status, while helping each person develop a more humanistic frame of reference for themselves. We can also make social service referrals for elderly patients, which enhance their individual adaptive capacity while lessening the debilitating environmental conditions they face when in dependent positions. And we need to design our therapy interventions to help empower the patient and foster self-determination. This often means divesting some of our own power and control as a healthcare advocate while helping the patient develop self-confidence, and an internal locus of control. Our success should be measured by the patient's ability to sustain gains made in therapy and to demonstrate new adaptive problem-solving strategies learned in therapy. I want to finish by briefly touching base with several specific psychosocial issues pertinent to the older adult. The first is sexuality. In the absence of disease, sexual capacity is lifelong. Even when and if sexual intercourse is not an option because of illness or infirmity, the need for other aspects of an intimate relationship, such as closeness, sensuality, and feeling loved and valued, still exists. Often it is a physical therapist to whom the patient initially turns with questions about sexuality and/or sexual function. While most of us are not trained counselors, all of us can provide the patient with an attentive ear while creating an atmosphere of caring and concern. This helps legitimize the person's question and makes them receptive to specific advice or to recommendations you may choose to make regarding professional intervention. The next topic is ageism, a prejudicial attitude often projected onto the elderly. Some typical examples include equating memory loss with dementia, treating the person in a childlike manner, talking around the person rather than to him or her, imposing our values onto the older person, using elder speak, a condescending tone of voice, or employing inappropriate terms of familiarity, such as sweetie or granny. Your first job as a therapist is to do some soul searching and eliminate any symptoms of ageism from your own interactions. And when you encounter it in others, you should proactively empathize with the person while taking reasonable steps to reduce their exposure to this subtle form of psychological abuse. This leads us to another topic, namely elder abuse. The American Medical Association published guidelines in 1992 for the diagnosis and treatment of elder abuse and neglect. It listed 7 specific areas which are typically covered by state laws: physical abuse, sexual abuse, psychological or emotional mistreatment, violation of one's rights, financial or material exploitation, active or passive neglect, self-neglect. It is the responsibility of the physical therapist to become familiar with signs of abuse and with the appropriate method of reporting suspected abuse. I will close with one final note on the role of the family in elder care. In the U.S., the family has served as a primary safety net for the social, psychological, and financial needs of older persons. Simultaneous increases in life expectancy and decreases in fertility are leading to more elders with fewer young family members to support them. All evidence suggests that families possess the intent to care for their elders, but their capacity to do so effectively is often challenged. Thus, the need for home-based care provided by informal caregivers will continue to grow. Physical therapy has a role to play in the education and development of these caregivers, both individually and on a community basis.